this
Uh,
thing.
Shishir, can you just start
Yes.
from the beginning? Just one second. I was disconnected once.
Okay. I'll start now, sir.
Hello.
Can I start now, sir?
One second. Some problem with my audio. One second. Hello.
Hello, sir.
Yeah. Now audible. Yeah, you can start.
Okay. So today's seminar is on the topic retinopathy of prematurity. So before understanding its pathogenesis, so first let us have a look on normal retinal vascular development. So retinal vessels begin to grow from disc to the periphery at 4 months of gestation, and it will reach the nasal ora serrata at 8 months. So the temporal periphery will be completely vascularized shortly after term. So hence, in a premature infant, there is peripheral avascular retina. So recent studies by Flynn et al. Demonstrate two phases in retinal vascular development. The first phase is vasculogenesis, so which results in formation of four major arcades of posterior retina from mesenchymal vascular precursor cells. Though this first phase begins before 14 weeks of gestation and completes by 21 weeks. The second phase is called angiogenesis, which results in the formation of remaining vessels by budding of endothelial cell from vessels formed in the first phase. So this is the diagram depicting a normal retinal vasculogenesis. It starts at 4 months from disc and proceeds to periphery. So first the nasal ora serrata is vascularized at 8 months, and shortly, nearly 4 weeks after the birth, normal term birth, nearly at 10 months of gestation, the temporal retina will be fully vascularized. So the pathogenesis of this is so when the infant is subjected to continuous and prolonged oxygen, the developing retinal vessels undergo hyperoxic reflex vasoconstriction. So this is referred to as hyperoxic hypoxia. So the mature retinal arteries and veins which are developed till now will survive this insult. However, the developing capillaries at the junction of vascular and avascular retina, they get destroyed with this excess of oxygen, which is subjected. So, in place of developing capillaries, the remaining vascular channel they form a arteriovenous shunt at the junction of vascular and avascular retina. So, during this acute phase of ROP, the hypoxic peripheral retina this releases angiogenic factors that have potential to derive both normal and abnormal neovascularization. So prominent factor is among those angiogenic factors are vascular endothelial growth factor. So 90% of times the mesenchymal shunt regresses with normal vascular channels forming inside the retina and reaching temporal ora serrata. So in progressive ROP, the primitive endothelial cell, in the mesenchymal shunt proliferate and erupt through internal limiting membrane growing on the surface of retina and ultimately into the vitreous. So further proliferation results in fibrovascular membrane formation and at later stages, it may also lead to retinal detachment. So this is the flowchart depicting the pathogenesis. So when, especially in the premature babies with premature birth, so subjected to oxygenation for various systemic conditions, they have increased oxygen load, leading to the capillary closure and then leading to neovascularization after when the oxygen supply is stopped. So here you can see generally high risk gestational age is 22 to 30 weeks of gestation, and first examination is done between 32 to 34 weeks generally. And so if there is an risk of aggressive posterior ROP, it can develop between these 32 to 34 weeks, and generally stage 1 ROP can also develop and stage 2 and stage 3 in the subsequent weeks, 36 to 35 to 36 weeks. So, coming to zones of ROP, so there are three zones: zone 1, zone 2, zone 3. So, zone 1 is the imaginary circle where the optic disc is at the center, and the radius of that circle is double the distance between optic disc and center of macula. So, if you draw the circle, the zone which is forming is called as zone 1. And zone 2 is between the nasal end of the zone 1, and the radius is between nasal end of the zone 1 and to the nasal ora serrata. So when you draw the imaginary circle, the zone becomes zone 2, and the temporal retina beyond zone 2 is called as zone 3. So the recent classification is the ICROP stage 3 classification, which was done in 2019. They also included posterior zone 2, that is zone 1 anterior 2 disc diameter anterior to the zone 1. Edge of the zone 1 is also called as posterior zone 2 because why they have classified that as a separate posterior zone 2 is so the disease activity at that zone will sometimes have the characteristics similar to even zone 1 ROP. They can behave like zone 1 ROP also. That's why they have classified it as separate posterior zone 2. So coming to stages of ROP, again there are few changes made in the recent classification. So first is incomplete retinal vascularization. Actually, the term no ROP or immature retina is generally not used now. So the better term they have coined is incomplete retinal vascularization, where you can see avascular retina, but without any other fundus features such as dilatation or tortuosity or new vessels. Nothing is there. You are only seeing avascular retina, the peripheral avascular retina. Then you can term it as incomplete retinal vascularization rather than no ROP or immature retina. Then coming to the proper stages, first stage is the demarcation line. So here you can see the line. You can see the thin whitish line in the temporal periphery, which is demarcating this vascularized and avascularized retina. So basically, anterior to this line is there is avascular retina. So posterior to this line is the vascularization of retina. So this line is the demarcation line. So it is a flat line between vascular and avascular retina. So coming to stage 2, it is called as ridge. So when this line progresses, it will have the width and the height. So when you can see the width and the height in that in the demarcation line, you can call it as ridge. So generally, the anterior to the ridge, there may be small tufts of vessels which are not called as popcorn lesions. You may see, but they will not be overlying the ridge. They will be just anterior to the posterior to the ridge. So this is stage 2. In stage 3, there is extraretinal fibrovascular tissue. So where you can see the now in stage 3, you can see the new vessels which are actually overlying that ridge. So that is the difference between stage 2 and stage 3. So where you can see more new vessels which are overlying this ridge. So now coming to stage 4, in stage 4 ROP, you will see subtotal retinal detachment. Again, stage 4 is being classified as 4A and 4B. 4A is which is sparing macula. So here, this is stage 4A, the image which I have put here. So here the macula appears attached only. So the peripheral retina is getting detached. So this is stage 4A, which with areas of hemorrhages also. So in 4B, you can see this same subtotal detachment, but it will be involving the macula. So stage 5 is total retinal detachment. So where you can see entire retina being lifted off. Generally, the type of retinal detachment is tractional retinal detachment seen in ROP. So again, recent classification, they have classified stage 5 as stage 5A, 5B, 5C. So in stage 5A, optic disc is visible. That is like open funnel retinal detachment. In 5B, the optic disc is not visible. That is like closed funnel detachment. And in 5C, along with the retinal detachment, you can see the anterior segment findings also, such as rubeosis iridis, shallow anterior chamber, posterior synechiae, and neovascular glaucomas and all. Then that is 5C. So to summarize, the picture A is showing the demarcation line, and picture B, the line is progressing to the formation of ridge. And in C, you can see ridge with extraretinal fibrovascular proliferation. And in D, you can see there is subtotal retinal detachment, so it's getting detached from the periphery. And in E, you can see the total retinal detachment. So there is another term called as plush disease. So when the posterior pole veins are enlarged and the arterioles are tortuous in at least two quadrants, a plus sign is added to the ROP stage. So this plush disease, the term they have coined to tell the severity of the disease. There may be iris vessel engorgement with extension into the anterior lens surface also, and pupillary rigidity and vitreous haze may be associated with it. So generally, when you try to dilate the baby, if you are not achieving the adequate dilatation, then one thing you can assume is the baby might be having plush disease. So any dilatation and tortuosity less than the above described is pre-plush disease. So for example, if dilatation is there in only one quadrant or partial quadrant, then you can tell it as pre-plush disease. So this is the picture showing plush disease, where you can see in both the temporal, superior and inferior temporal quadrants, veins are enlarged, congested, and arteries, you can see a lot of tortuosity in the arterioles. And now the pre-plus disease will progress to plus, and there is another severe variant of the disease called as aggressive posterior ROP. So this is fulminant type of ROP, which is characterized by severe plus disease with flat brush-like proliferation with vascular loops and hemorrhages. So generally, plus disease is one of the signs of aggressive posterior ROP. You can tell like that. So in this type of ROP, it is often encountered in zone 1 or posterior zone 2, and it will progress to stage 5 directly without passing through the stages 1 to 3. So this aggressive posterior ROP term came because not all the ROP will progress from stage 1 to stage 3 as described before. So this aggressive stage is such that you will not see any stages. You sometimes you will not see the demarcation line, ridge, or anything. It may directly end up in detachment. So here the generally features are like retina will appear stable only, but there you can see the neovascularization at the posterior pole, capillary loops and arteriovenous shunts and all you can see, and tortuosity, dilatation and all you can see. So this is aggressive posterior ROP, which requires urgent treatment. So previously it was known by various names such as rush disease, type 2 ROP, and fulminant ROP. So this APROP was coined in 2005. So again, a newer classification, they have terminated that the term APROP. They have just called it as aggressive ROP. Why means, as I have told, so not only the posterior zone will lead to aggressive disease. Sometimes the zone little bit anterior to zone 1 can also lead to the severity similar to the APROP. That's why they just removed that term posterior. They just called it as aggressive ROP. So it is involving posterior zone. Generally, you will see featureless, deceptive featureless junction. Flat neovascularization is seen, and with associated severe plush disease. And it will progress rapidly without stages, and there can be dilated vascular loops, arteriovenous shunting. So this is the image of aggressive ROP. So you can see nearly all the vessels are enlarged and arterioles are this thing tortuous. So retinal development is hardly completed till zone 1. So this entire area is avascular retina. So this requires urgent treatment, or else it can directly progress to stage 4 or stage 5. So, what is spontaneously regressed ROP? So, changes can be seen in spontaneously involuted ROP depending on severity of initial disease. So, peripheral changes include abnormally branching or telangiectatic retinal vessels, pigmentary changes, lattice-like degeneration, vitreous membranes. So, posterior pole changes include tortuous vessels, narrow temporal arcade, disc drag. And infants with spontaneously regressed ROP may develop myopia, the mechanism which is still obscure. It has, however, been correlated to initial stage of ROP. Amblyopia, nystagmus, strabismus are also common in spontaneously regressed ROP. So coming to screening, which infants to be screened? In Indian scenario, infants weighing less than 2 kgs at birth or less than 34 weeks of gestation are eligible infants for screening for ROP. So heavier or older babies may also be included if they are having any risk factors such as prolonged ventilation or oxygen administration and hospitalization or any other very adverse systemic condition. So screening protocol. So first screening examination of ROP should be done after 3 to 4 weeks of birth, irrespective of gestational age. So as a simple rule, each premature eligible infant should receive one examination by day 30 of life. So after the screening, whether to treat or to further observe is depending on early treatment retinopathy of prematurity guidelines. So if there is zone 1 ROP with no plus disease, if stage 1 or 2, you can follow up after 1 week after the first screening. In stage 3, you have to treat that case. And in cases of plus disease, stage irrespective of whatever stage, up to stage 1, 2, 3, you have to treat in zone 1. So in zone 2, if there is no plus, up to stage 3, you can follow up 1 to 2 weeks. And in zone 2 plus disease, stage 1 you can follow up, but stage 2 and stage 3 requires treatment. RETCAM based screening. So there is advance in screening for ROP is the introduction of wide angle fundus viewing fundus photography using RETCAM. So image capture is a palm sized digital color fundus camera using fiber optics specifically designed for vascularization of for visualization of retina of premature infants. So it will give up to 130-degree of the angle, and it provides dynamic image of premature retina and facilitates capturing only those images which are desired. But still, indirect ophthalmoscopic examination still remains the gold standard examination. So the advantage of this RETCAM is photo documentation of ROP and monitoring the response to laser or anti-VEGF treatment, and mass telescreening setup. You can use this RETCAM, and you can immediately share the image to the ophthalmologist who is expert in diagnosis and treatment of retinopathy of prematurity. So coming to management of this, earlier cryotherapy was used to ablate the peripheral avascular retina. So the complications with the use of cryotherapy was more, and the posterior zones were not able to be treated due to non-accessibility of this cryotherapy. So now cryo ROP guidelines are no longer used. Coming to laser treatment, so ETROP study showed that laser treatment for high risk pre-threshold ROP significantly reduced unfavorable outcome. So according to the study, the indication for laser treatment are high risk ROP. That is a disease with high risk progression. That is zone 1, stage 1 to 3 ROP with plus disease, as I told before. Zone 1, stage 3 ROP without plus disease, and zone 2, stage 2 or 3 ROP with plus disease. So these are the common this thing variety of disease where you need a laser treatment, and aggressive posterior ROP. Plus disease after ETROP study means that at least 2 quadrants of dilatation and tortuosity of blood vessels should be seen, and it is a marker of significant disease. So continued follow-up, generally weekly follow-up is advised until spontaneous regression of ROP is noted. And Follow-up is done in these cases. Zone 1, stage 1 or 2 ROP without plush disease, and zone 2, stage 1 to 3 ROP without plush disease can be followed up, and peripheral avascular retina without any stage of ROP. These infants can be followed up. So procedure is informed consent to the parents and legal guardian should always be taken. And we have to beforehand explain the complications associated with laser and long-term sequelae. And the retreatment and need for glasses should also be explained, because most of these infants will develop myopia post laser. And feeds to the infant should be withheld for at least half an hour prior to laser. Under topical anesthesia, you can perform the laser. It is better to be monitored by neonatologist or anesthesiologist. A portable diode laser or frequency doubled Nd:Arc laser or an argon laser can be used for the treatment. So the laser is delivered through indirect ophthalmoscope delivery system. So it is diode LIO system is most commonly used and preferred worldwide because of better penetration in the eyes with tunica vasculosa lentis. And infant lid speculum is placed, and 20 or 28 diopter aspheric lens can be used for visualization, and nearly 300 to 400 power and duration of 300 to 400 milliseconds are the settings. So light gray burn we should be able to achieve, and the aim is to ablate entire avascular retina from ridge up to ora cerebri. When you are seeing the ridge, we should avoid lasering the ridge because it can cause vitreous hemorrhage or progression of ROP. It can lead to progression of ROP also. So we have to laser anterior to the ridge. So the complete avascular retina we have to cover. And there is no need to laser the vascular normally developed retina. We should not do PRP. We should do only in the avascular regions. So follow-up is the first follow-up is done at 1 week. So you can assess the extent of plush disease and presence of any skip areas and status of ridge or any presence of fibrovascular proliferation and tunica vasculosa lentis, any vitreous organization or presence or absence of vitreous hemorrhage. These are the things to be noted at first follow-up. And at 1 week, if significant plush disease is still present, so additional laser may be done. So if you are not seeing any response at all after 1 week of laser, then you can add additional laser to the skip areas. So plush disease without skip areas, prominent ridge or area of fibrovascular proliferation needs to be followed closely at weekly intervals. So if there is significant regression of plush disease, then follow-up can be done at 2 weeks. So till regression of disease is complete disappearance of plush disease and any active neovascular tissue. So if it is completely disappeared, then it is called as regressed ROP. Then this usually completes within 6 to 12 weeks following laser. If there is significant fibrovascular organization in the vitreous, the infant is followed up again closely for development of retinal detachment. So less than 3 clock hours of extramacular detachment may be observed because fibrovascular membrane it will separate into vitreous cavity, relieving traction and leading to spontaneous regression. However, if retinal detachment progresses to 4 or more clock hours, then lens sparing vitrectomy is indicated. So coming to anti-VEGF therapy, it is indicated in treatment for stage 3 ROP with plush disease in zone 1 and in aggressive ROP. So basically, posterior ROP, zone 1 ROP or aggressive ROP, first line of treatment nowadays is anti-VEGF therapy, because anti-VEGF allows for normal vascularization of the even avascular retina. So you can give anti-VEGF and observe for the normal vascularization, and later on you can add laser therapy if there is still persistent avascular retina. So in zone 1, the the infant will benefit with anti-VEGF therapy. So the dosage with this BEAT ROP study and Rainbow study, this BEAT ROP is for bevacizumab and Rainbow study is done for ranibizumab. So it is the first anti-VEGF which is approved by European Union for treatment of retinopathy of prematurity, severe ROP. So ranibizumab dosage is 0.2 mg and bevacizumab is 0.5 to 0.6 mg. Generally, you can consider half the dosage of adult dose. So, treatment with aflibercept study has also been found beneficial, which was non-inferior to laser in clinical trials. So, anti-VEGF therapy has more advantages and easier to treat, as well as it will take less time and it will allow the normal retina to develop to at least zone 2 or till zone 3. So, coming to surgical management. So, as I said, lens sparing vitrectomy for ROP is done using 23, 25, or even 27 gauge vitrectomy. So, sclerotomies are made 1 mm posterior to the limbus through pars plicata. So, entry is vertical to avoid hitting the lens. And the aim of surgery is to remove as much as proliferation as possible. And in stage 5 ROP, layers of proliferation are dissected sequentially with vitrectomy cutter as well as intraocular scissors. So first the ridge to ridge and whatever traction horizontal vertical traction as well as horizontal traction is there, that has to be relieved from posterior pole to the periphery. So the posterior hyaloid cannot be removed due to the firm attachment. So peripheral vitreous attachment of the ridge require careful segmentation to prevent iatrogenic break. So thus the ridge should be basically freed from all the traction, and indirect examination should be done with scleral depression to note any breaks in the retinal periphery. If no breaks are noted, only BSS is infused. If retinal breaks are noted, then fluid air exchange is done and intraocular gas or even silicone oil tamponade can be used. So in ETROP study where both scleral buckling and vitrectomy was used, the functional outcome of retinal detachment was generally poor. Anatomical macular detachment, macular attachment could be achieved only in 33 percentiles. So with advances in surgical techniques, surgeon performing lens sparing vitrectomy have reported higher anatomical success rate in recent series. So around 90% success rate is found, and Lakhanpal et al. Reported 85% of eyes with 4A, 4B TRDs secondary to ROP were completely reattached with single surgical procedure, and nearly 95% were ultimately partially reattached at posterior pole by the final follow-up visit. So similarly, Shah et al. Reported that anatomical outcome was 90% for stage 4A. So late identification of disease, lack of prior treatment such as laser or cryo, and higher incidence of narrow funnel configuration leads to a poor surgical prognosis. So this is the flowchart of management of patients with ROP. So aggressive ROP or zone 1 ROP with stage 2, stage 3 should be first treated with anti-VEGF therapy and followed up closely. Then, if there is still persistence of avascular retina, then we'll go for laser to the avascular retina. And if there is progression to the retinal detachment without vascular activity, without hemorrhage, then you can directly go for vitrectomy. If there is lot of new vessels, then prior you can inject anti-VEGF and then later go for vitrectomy also. So anti-VEGF therapy is indicated in posterior ROP type 1 and with rubeosis iridis with vitreous haze, and if the infant is very sick for laser, then in such cases anti-VEGF are given. Anti-VEGF plus vitrectomy is to retinal detachment with vascular activity. Only vitrectomy is where there is traction and only vitreous hemorrhage is there, no vascular activity, then you can go for only vitrectomy. So when you should not action, or when there is already the stage is 4A where there is peripheral retinal detachment is there already, at that time you should not inject anti-VEGF because it will progress to 4B or even 5. So that caution we have to keep. Thank you.
Yes, very good. I think overall it was everything was covered. About anti-VEGF, there has been recent report that see, after anti-VEGF, you have to still follow up the patient because there is a chance of recurrence of ROP. So you have to follow up whether the vessels are progressing or not. And in some cases, they have reported that after even anti-VEGF, after 3-4 months, there can be a recurrence. So we should be able to treat that also. And practically,
Yes.
most of the retina specialists, they are suggesting that bevacizumab is better than ranibizumab in terms of recurrence of ROP. But in studies, not much of a difference has been noted. So that is one thing about anti-VEGF. But laser is still the gold standard. So many retina specialists still after anti-VEGF, if the plus sign is reduced, then after that they will laser the avascular retina. Okay. Any questions, Shishir or anyone else?
Anti-VEGF injection, how much duration should we wait for the vessels to regress? How to keep the follow-up? And if the vessels don't regress, then we have to laser the vascularity.
Shishir, can you repeat the question?
After giving anti-VEGF, how long we have to wait for vessels to regress? And what if the vessels did not regress?
So it has not been shown that after anti-VEGF the vessels do not regress. They will always regress because you are correcting the VEGF inside. Usually in a week's time it should start regressing. Main thing is we have to look for how the vessels are progressing further towards the periphery. And only place
Okay.
where you have to laser is that if there is less response or still the plus sign recurs, or there is vascularization is still persistent, then after a week or 2 weeks also you can start doing laser if you feel that the response is not adequate. But if response is adequate, you
Okay.
can just follow.
As the baby grows, the eye will also grow. So, like anterior to the laser area, there will be again some avascular retina which will develop. So, that retina also has to be lasered, or that can be just observed.
Shishir, can you repeat?
So, as the baby grows, the area
No,
anterior to the
can't
laser will also develop.
can't hear properly. Somebody
Sir,
closer to the laptop.
sir, as the baby will grow, the eyeball will also grow. So, area anterior to the laser will also develop. That may be avascular. So, that also needs to be lasered, or that can be observed.
We can observe that patient.
Okay.
Okay, thank you. Good
Thank you.
presentation, Shishir. Okay.